I need to be very clear at the start of this presentation that this presentation is focused on providing only a very general overview of autism and some of the major issues that commonly occur when living with or assisting a child or adult with autism. Many of the topics covered in the presentation could easily be expanded into one or more specialized presentations of their own. While we'll be spending some time on the diagnostic criteria of autism, this is not a presentation on how to do a clinical diagnostic assessment of autism. Even from our brief introduction into this topic, however, you may gain an understanding of how complex it actually is to do a proper diagnostic assessment. Treatment, of course, is a very critical topic. We'll be focusing on what is termed empirically supported treatments, which is in fact the only kind of treatment that most people think of when they themselves go for treatment. This is in clear distinction to pseudo-treatments or more experimental but as yet unsupported treatment options that are routinely marketed as cure-alls or the next best thing for children and adults with autism. We'll be covering empirically supported treatment options more extensively in other presentations. Planning and service options are also very complex and large topics. Many people with autism require extensive, complex, and ongoing assistance. This requires expert planning and service provision in order to adequately address the child or adult's needs. We will highlight only a few of the areas where planning and service provision issues often arise. Before jumping into the main topics of this presentation, it is good to go over a little history regarding autism. Autism has a long history that goes back into the early 1800s. Itard, a French physician, described a child named Victor over 200 years ago that is relatively agreed upon to be the first clear description of what would later be viewed as autism. Jumping forward nearly 100 years, Eugene Bleuler, who first defined schizophrenia, introduced the term autism as a descriptive term for certain aspects of what he was observing in patients with schizophrenia. He was identifying characteristics of aloofness or ambivalence to the world around the individual. Leo Kanner in the early 1940s presented the first persuasive argument that childhood autism is a separate condition from other conditions such as schizophrenia, psychosis, or intellectual disability. As it turned out, this initiated long-term debates regarding the relationship between what we now define as autism and schizophrenia. In many places, autism did not become a common term for the condition until many years later. Shortly following Kanner's publication, Hans Asperger also published his work identifying a very similar set of symptoms in his work with children in Austria. While there has been much discussion regarding the similarities and differences between Kanner's and Asperger's original descriptions, current research indicates that it is not possible to truly tell them apart. This has led to the current DSM-5 diagnosis of autism spectrum disorder, which also incorporates what used to be called Asperger syndrome. It was not, in fact, until 1980 that autism was officially recognized as a separate disorder in the Diagnostic and Statistical Manual of the American Psychiatric Association. It can be seen by this brief historical review that while autism has a long history, it has only been in the last 40 to 50 years, since it was formally recognized as a separate diagnosis, that much of the research on autism as a specific diagnosis has actually taken place. Defining the syndrome is one thing. Figuring out how to treat it is something else altogether. From Kanner and Asperger's work in the early 1940s through to the late 1970s, work on autism focused predominantly on further exploring its characteristics, related medical conditions, and largely around institutional care, as no effective treatments were known. Only the very highest functioning people in those days tended to remain in the community at large. Many individuals were cared for in isolation by their families, or if demonstrating significant problems, then living in institutional facilities. The view from the mid-1940s through to the 1960s was largely that autism was being caused by inappropriate parenting, particularly cold and aloof mothers. This hypothesis was first suggested by Kanner, who later recanted this idea. It was, however, widely supported by psychoanalytically, that is, Freudian-trained psychiatrists and psychologists. Bruno Bettelheim was the major flag bearer for this idea. In the early 1960s, parent support and advocacy groups emerged. Dr. Wing, an English psychiatrist, in 1962, and Dr. Rimland, an American psychologist, in 1964, both parents of children with autism, started the first two national-level groups to build support for families and individuals dealing with autism. Rimland's work led him to suggest that autism was more likely a biological rather than a socially emotionally caused disorder. This proved to be a major turning point in the view of autism. It would, however, take years more before the refrigerator mother viewpoint of the cause of autism was virtually completely abandoned. Kanner, in one of his later papers, identified that the issue may be that the mother's behavior and mental health at the time the children were being brought in for diagnosis may be the result of trying to parent the child rather than the cause of the child's behavior. Up to the mid-1960s, it was commonly believed that children with autism could not learn from the consequences of their behavior. By 1965, researchers such as Bellamy, Colligan, Lovas, Pace, and others started to discover experimental treatments that produced the first demonstrations that children with autism could learn. The purpose for doing some of this early research was in fact to demonstrate that the children could actually learn and thus may benefit from treatment. The Diagnostic and Statistical Manual, DSM, published by the American Psychiatric Association, is the major mental health diagnostic manual used in the United States and Canada. The other major diagnostic manual used in many parts of the world is the International Statistical Classification of Diseases and Related Health Problems, ICD. Both share a similar general history regarding the adoption of autism as a specific diagnosis. Autism throughout all the DSM editions has and continues to have a changing status. Autism was not mentioned prior to 1968. In the second edition of DSM, it was mentioned, but as a descriptor term within the diagnosis of schizophrenia, childhood type. Only in DSM-3, published in 1980, did autism become a uniquely defined diagnosis. In DSM-4, published in 1994, Asperger's syndrome was included. DSM-5 no longer recognizes Asperger's syndrome as being different from autism. In some sense, autism can be seen somewhat as a moving target. However, it does turn out that the core aspects of autism have been clearly defined for some time. What is causing the shifts across the later editions of DSM are attempts to clarify wording ambiguities, to improve the consistency and reliability of diagnostic practice, and adjusting to ongoing research results. Up until 1980, when DSM-3 was published, research in autism was hampered by not having a clear definition of what the disorder was. The implications of such confusion had significant impacts on aspects ranging from basic research through to funding policies for services. Currently, however, research seems to be quite conclusively established that autism should be viewed as a spectrum disorder rather than as a too rigid single entity. The biomedical research concerning autism and schizophrenia can obviously be traced back many years. The focus has changed from more descriptive research regarding the similarities and differences regarding symptoms to studying possible genetic links between the two disorders. It is hoped that should solid evidence be discovered of stable genetic links between autism and schizophrenia, that there will be a big development in their understanding of the biology of both disorders. The ability to do a long-term systematic research program for children with autism is affected by the changing criteria for diagnosis, as well as the changing availability of diagnostic tools. It is critically important when reviewing literature over the last 30 to 40 years that you be aware of what the diagnostic criteria of the time was. As well, you will need to know what diagnostic instruments or methods were used. Without such knowledge, looking over time at much of the research regarding autism will likely only be confusing. This issue is the case for both basic medical research as well as research into treatment effects. For instance, currently there are far more young children diagnosed with milder symptoms of autism than was the case even a short time ago. This means that it is very likely that the selection of children into research programs in, say, 1999 would be different from the selection of children today. It appears that the biggest factors contributing to the rise in the incidence of autism is due to changes in diagnostic criteria, diagnostic assessments, and public awareness. As can be seen, this diagnostic criteria is focused on social communication and relationships. The deficits specific to autism are not related so much to simple limitations in the amount of social communication and interactions, although these are part of the issue for many individuals with autism. The criteria is more focused on the odd or abnormal manner in which individuals with autism may attempt social interactions. It is in fact more the oddness or abnormality of the social interactions that stand out as the hallmark of autism. For some individuals with higher intellectual capacities, there is no lack of trying to have social interactions and relationships. However, most attempts never lead to typical outcomes or expected levels of deeper social relationships. Such deficits are oftentimes called pragmatic deficits to distinguish them from a range of simple language or social behaviors. A person may actually score quite well regarding simple language or social behaviors, but have such difficulty putting them all together in everyday interactions that they have very significant practical problems in social relationships and the social nature of language communication. Needless to say, developing the full explanation of what these deficits actually are is very challenging and will change over time as new research points to better ways of describing the deficits, as well as discovering potential new aspects of the core deficits. It is very clear, of course, that individuals with autism have a range of strengths and capacities. These strengths, however, have not been found to be helpful from a diagnostic point of view, which is why you'll see the diagnostic criteria focusing on the deficits that most clearly distinguish autism from any other disorder. As can be seen from these 4 points, the main focus relates to issues of repetitiveness or restriction. The point regarding hyper or hyporeactivity is in reference to some interests or fascinations having particular sensory-oriented components, such as a fascination with lights or spinning objects. Again, it is more the rituals or reactions to various stimuli that are the critical factor from a diagnostic point of view. Simply having various fairly rigid routines, of course, does not mean someone has autism, nor does a particular sensitivity or insensitivity to particular sensory stimuli. We all have components of our routines that are fairly rigid, for instance, getting dressed using a fairly specific order every day. And many people, for instance, complain about fluorescent lights. Other people, of course, may choose to ride repetitively on a roller coaster, while others wouldn't go near a roller coaster. Diagnostically, it is important to decide both how atypical the pattern of behavior is, given the age of the child, as well as whether the behavior is in fact interfering with the child or adult's life. For instance, it is not all that uncommon that typical infants will, at least briefly, engage in obvious self-stimulatory behavior, such as rocking, or even self-injurious behavior, such as headbanging on the side of the crib. However, such behavior tends to be short-lived and overall not particularly atypical for the child's age. When such inflexible and restrictive behavior patterns start to interfere with the child's development or the adult's engagement or access to age-appropriate activities, such behavior patterns are viewed much more critically. On the other hand, relatively simple and/or infantile self-stimulatory behavior, for instance licking objects or smelling objects, need to be viewed carefully, as they are also associated with greater degrees of intellectual impairment independent of autism. The issue of when symptoms were first noticed is essential for making a diagnosis of autism, as compared to possibly a different diagnosis. This can become an issue for children with milder symptoms who may not be brought to the attention of a diagnostician until they are much older. At this point, parents sometimes have difficulty remembering if their son or daughter showed such symptoms in early development. This can be particularly challenging for immigrant families, not only due to a possible language barrier, but also to issues surrounding the timing and reasons why the family left their country of origin, as well as cultural parenting factors. The Autism Diagnostic Interview Revised, the ADIR, is a very well-designed interview protocol that aims to assist parents in placing the onset of symptoms at an accurate point in time. For older children and adolescents, only through a competent administration of the ADIR or through a sophisticated clinical interview can the issue of the timing of the onset of symptoms be properly addressed. The Autism Diagnostic Observation Schedule, the ADOS, is another well-designed diagnostic tool. However, it focuses on current functioning and thus for older children is not helpful for investigating the age of onset. Onset of autistic-like symptoms in later childhood with an obvious history of typical development up to that point strongly suggests that whatever the problem is, it is more likely something other than autism. There are in fact a number of alternative diagnoses that need to be evaluated when assessing a child for autism. This is the core feature of making a differential diagnosis, meaning two or more diagnoses were viewed as potentially accurate diagnoses, but through the diagnostic assessment process, various diagnostic options were excluded. If children were only assessed for symptoms of autism without a broader differential diagnostic process occurring, it is very likely that a number of children would be thought of as having autism when in fact they have a different diagnosis. It is of course possible that the child will have more than one diagnosis. It is currently estimated that about 70% of individuals with autism may have one comorbid mental disorder and about 40% may have two or more co-occurring mental disorders. Autism is also frequently associated with intellectual impairments. Making such a complex multiple diagnoses is very challenging. It is also quite possible that the disorders start at different times, thus necessitating several diagnostic assessments. For example, a child may be diagnosed with autism spectrum disorder before the age of 3, then be diagnosed with a learning disability or intellectual impairment when they are 10 or 11 years old, and then is having an anxiety disorder as a teenager. Besides the obvious fact of trying to better explain the challenges the child or adult is having, being clear regarding his or her diagnostic profile has significant implications for treatment, services, and supports. To make consistent and accurate diagnoses of autism requires a fair amount of expertise and experience. While there are all sorts of checklists on the internet, pamphlets with brief diagnostic descriptions, etc., these only alert the reader to the possibility that the child or adult they are thinking about may have the diagnosis. The critical issue is making a proper diagnosis is establishing not only that the pattern of symptoms fits all of the necessary criteria, but also that it can be differentiated from other potential conditions such as Rett syndrome, late-onset childhood psychosis, childhood disintegrated disorder, or some combination of diagnoses such as an intellectual disability combined with obsessive-compulsive disorder. Treatment, expected course, and outcomes can all differ depending on the diagnosis. This is why it's typical for many jurisdictions to require that either a psychologist or physician make the diagnosis. Working in the area of autism also means it is possible that the diagnostician may need to make two or more diagnoses, such as autism and depression, or autism and intellectual disability. This not only makes the diagnostic process more complicated, but obviously requires that the psychologist or physician also have expertise in a wider range of likely co-occurring conditions. This type of situation is a major rationale for multidisciplinary assessment teams, as no single professional can oftentimes have the necessary training and expertise in all areas required to complete a comprehensive assessment. Age at which the diagnosis is made can be an issue as the presentation of symptoms can change over time. Such changes in symptom presentation can occur not only for various biological reasons, but also due to the person's learning history. It is also more likely that it will be individuals with milder symptoms in the first place who may only later be seen for a diagnosis. Such individuals likely had harder to recognize symptoms as a young child, making the diagnostic process particularly difficult. It is when the demands of the current situation places too much stress on the older child or adolescent's ability to adapt that the symptoms become more obvious and thus a diagnosis is made. As compared to the 1990s and earlier, we have two quite well-developed and standardized assessment tools. The ADOS, or ADIR, can be used either individually or in combination to make a diagnosis. Using them in combination, due to their very different approaches, adds the benefit of addressing the issue from different perspectives. If both a detailed structured observational approach, the ADOS, and a comprehensive developmental history interview, the ADIR, both determine the child has autism, the confidence in the diagnosis can be very high. As with any multi-method approach, however, the situation does arise when the assessments give different results, thus making a determination of a diagnosis particularly challenging. Since the 1970s, several other diagnostic tools have been developed. An ongoing issue, however, is the level of research support the tools have demonstrating that they have what is called good or sufficient psychometric properties. These psychometric properties are important for determining how well they work for making accurate diagnoses. There is, of course, the option for a very well-trained and experienced clinician to be able to make a diagnosis without using such structured tools. However, there are very few such clinicians available, and there could be some concern regarding the reliability of their diagnoses over time or across children. At this time, having a well-trained and experienced clinician use the ADOS and/or ADIR is optimal. The publishers of both assessments offer extensive training options for each tool. It is clearly advisable that the clinician taking such training already have completed coursework in observational and interview methods, as well as in autism and related developmental disorders, prior to taking the specific training for the ADOS and/or the ADIR. As mentioned a few moments ago, using both assessments means it's possible to end up with competing and/or inconclusive results. For older, higher functioning children, for instance, who have learned a number of adaptive strategies, it may be that they score above the diagnostic criteria on one assessment, but below the criteria on the other assessment. As well, understanding how the effects of a co-occurring condition could affect the presentation of symptoms requires that clinical judgment be used to make a final determination for a number of children or adults being assessed. Thus, even when using the most developed diagnostic protocols, the diagnostic process can still present significant challenges and requires a sophisticated clinical judgment. The time gap between Kanner's discovery of autism and it being included in the DSM indicates how controversial the diagnosis was for many years. Its relationship to schizophrenia in particular has had a long and complex history. Partly due to the qualitative aspects distinguishing ASD from other diagnoses, there have been several attempts to develop more consistent and reliable diagnostic structures to assist in making the diagnosis. However, the essential details of ASD showing predominantly social, language, and restrictive or repetitive behavior symptoms has been at the core of all diagnostic structures since the 1980s. While Asperger's syndrome and PDD-NOS have been used in previous editions of the DSM, research has demonstrated that these cannot be reliably distinguished from autism. This has led to the term autism spectrum disorder, or ASD, which is now used to cover all the variations from previous editions. The ability to conduct ever more sophisticated research on various diagnostic questions is why this decision has been made now as compared to earlier. Differential diagnosis is at the heart of proper and effective diagnoses of autism. This is both to ensure that the child truly has autism as compared to a different diagnosis, as well as to properly diagnose two or more possible diagnoses on top of having autism, if that is the case. In the next part of this presentation, we will discuss such issues as the prevalence of ASD, theories of possible causes, some of the more common co-occurring diagnoses, and a brief introduction into treatment options. We will now move to discuss such topics as the prevalence, causes, genetics, treatment, educational, and family issues of autism.